Pulmonary System Part 2. We're going to start with the pulmonary diagnostic procedures. We're getting there. Hopefully if you have questions you'll give me a call or ask me in class. Okay, your blood gases. And interpreting arterial blood gases, they're either compensated or they're not. I don't go in for partial compensation because if you have one set of blood gases, how are you determining whether they're getting better or they're getting worse? Now, if you have a series of blood gases, then you can do partial compensation. So, your PaO2, the normal value is 80 to 100. This is your plasma O2. This is the amount that is available for the tissues. In infants, the norm is 40 to 70. If you're over 60 years old, you can actually subtract 1 millimeter per year. But regardless of your age, if your PaO2 drops below 40, it is life-threatening and is a major, major problem. Now, your PaO2 will increase with supplemental oxygen, and you will hyperventilate due to anxiety, hypoxia, pulmonary embolism, or pregnancy, and that will affect your PaCO2. Your PaCO2 is your normal value is 35 to 45. This is your respiratory measure. CO2 is considered an acid in the body, so that the more you have, the more acid it is. The less you have, the more alkaline it is. If it's over 50, you're in respiratory failure. If it's under 35, you're either hyperventilating or it's a compensatory mechanism for metabolic acidosis. And as I said, hyperventilation can be due to anxiety, hypoxia, pulmonary embolism, pregnancy, exercise when you're not used to it. All sorts of different things can cause hyperventilation. If you are a healthy individual, you can consider the room air, or your FiO2, and multiply it by 5, and that'll give you your PaO2. So, 21% O2 times 5, you would have a PaO2 of 100 to 105. If your oxygen levels are decreased for 6 hours, your patient becomes hypoxic. Anytime you have a decrease in your PaO2, the cells don't have enough oxygen to do what they need to do. You go into lactic acidosis, and then that develops into metabolic acidosis. Your PaCO2 is a compensatory measure, is something that you can change within minutes. Your bicarb takes hours to days. And speaking of which, your bicarb, the normal is 22 to 26. It will decrease if you have diarrhea, ketoacidosis, lactic acidosis, renal failure. It will increase with fluid loss from vomiting, suctioning, diuretics, low potassium, administration of steroids or antacids. This measure, as a compensatory measure, this bicarb, is considered a base. It is alkaline. So the more of it you have, the more alkaline it is. The less of it you have, the more acid it is. Your SaO2 is your pulse ox, and this is the amount of oxygen that's combined with hemoglobin. So you have to know your hemoglobin level to make sure that your SaO2 is adequate. Normally, it should be greater than 95% on room air. Changes in your pulse ox, or SaO2, are due to changes in your hemoglobin level, decreased perfusion, or a vascular die. CBC needs to be done because you have to make sure that you have an adequate hemoglobin to transport the oxygen that's circulating. So actually you just need an H&H. What other lab work should be done? Well, PPD, if you think, or a MAN2 test, if you think the patient's at risk for TB, a BUN for your hydration status, sputum culture and sensitivity, if you think that you have an infection that might be there, which leads us up to your sputum analysis. This will be done if you think you have an infection. Now, your normal sputum is like a clear yellow, light yellow or white in color, and it should only be about 10 milliliters for the whole day. Bronchoscopy is where they actually take a tube and look down into the bronchial tree and get specimens, do washings. For bronchoscopy, your NPO for 6 to 8 hours. This can be done at the bedside if necessary in an ICU unit. Thoracentesis is removal of a large pleural effusion or removal of fluid. And if you remove too much of that pleural effusion, it puts the patient at risk for increased mortality because it increases the risk of pulmonary edema due to that increase in negative pressure. So, if you're doing a thoracentesis, patient usually sits up at the side of the bed, arms over the bed rail, and they'll go in the dependent area. Never remove more than 1,000 milliliters at a time, because that will cause rebound pulmonary edema. So you want to stop it part way. Talk to the patient. Make sure everything's going well. Give it 5-15 minutes somewhere while you're just standing there talking to them, making sure everything's okay. And if it's okay, then you can resume it again. But you don't want to remove it all at one time. Pulmonary function test needs to be done to assess oxygenation, the ability to get it in, the ability to get it out. You'll find the information for a pulmonary function test on page 1214 in Lamone. And that tells you how it's to be done and what the various intervals indicate. Keep in mind, they look at the vital capacity in order to decide if you can wean a patient off a ventilator. You need to know that they can inhale at least 10 to 15 milliliters per kilo to take a deep breath in. Their respiratory rate has to be less than 24 and more than 12. And their negative inspiratory force or pressure needs to be at least a negative 20 to a negative 25 centimeters of pressure, which means that they can take a deep breath in sufficient to do what they need to do. A ventilation perfusion, a VQ scan, a ventilation perfusion lung scan, a VQ scan, identifies areas of dead space. If you have, if the VQ scan is increased, you have an increased level of dead space. And you probably have a pulmonary embolism. You need to look at a chest x-ray. Now remember, with a chest x-ray, fluid that you hear in the lungs will not show up for at least 24 hours on the x-ray. So if it's a new onset crackles, they will not be there on the chest x-ray. So don't be surprised at that. Or if there were new onset crackles, you gave them a diuretic, and then did the x-ray will be clear. Your end-tidal CO2 monitor is done to identify changes in dead space. It's oftentimes used with patients that are on ventilators. Possible causes for an increase in dead space might be a decrease in pulmonary blood flow, a decrease in cardiac output, or lung disease. And then we have our pulse ox, our SaO2 or SpO2 level that we looked at and we've already talked about. Different calls for nursing for somebody who has respiratory disorder might be an ineffective breathing pattern or impaired gas exchange, activity intolerance, nutrition less than body requirements, and as you can tell, I'm using only problem statements that might fit, not the etiology. Nutrition less than body requirements, because when you have someone who has a breathing problem, it takes an additional 700 calories just to breathe. So it's really important that they get adequate nutrition. Knowledge deficit, anxiety, fear, others. Infection, altered role function, and body image disturbance, just to name a few. Just to name a few. Your goal as the nurse is to maintain an effective gas exchange, to make sure your patient gets adequate nutrition, to modify their lifestyle to promote oxygenation, and to improve their activity tolerance. Those are the primary goals of care. Now, as a physician, the physician needs to treat the underlying cause. Get rid of the problem. If it's pneumonia, put them on an antibiotic. If it's a pneumothorax, stick in a chest tube. I mean, they need to figure out what the underlying cause is and treat that. And then they want to promote adequate gas exchange. And in many instances, they'll do this by adding positive end expiratory pressure, or CPAP, which is continuous positive airway pressure. If their pH is less than 7.25, they'll put them on a ventilator because you need to maintain adequate gas exchange. You need to correct any acidosis. Now, current theory is unless the pH is less than 7.2, you do not give any bicarb. We used to give bicarb all the time. In fact, when that was one of the first drugs we would give when somebody arrested was an AMPA bicarb, because the assumption was they were in lactic acidosis and the bicarb would help. Instead, it just made it harder to get them out of the arrested state that they were in. So now we only give bicarb if the pH is less than 7.2. Nutritional support is mandated. You've got to talk to the doctor and make sure they order something. Remember, it takes an additional 700 calories just to breathe. And these people are not eating adequately anyway. They don't have the air to do it. They don't have the oxygen to do it. They don't have the appetite because they've swallowed all that mucus. So you need to make sure they get nutrition somehow, whether it's by tube feedings or TPN. You need to prevent any complications that might occur. Make sure that they ambulate or turn or have EPC cuffs, and because you don't want them to develop a DVT and pulmonary emboli. That just compounds your problems. And you need to administer the medications the physician will order. He may order a mucolytic to break up the mucus. Speaking of which, never, ever, ever put saline down an endotracheal tube, because it does not break up the mucus. Those little red things or pink things that the respiratory squeezes in there doesn't do anything, except if there isn't a blockage, it will cause an aspiration pneumonia, because it'll go directly into the lungs, and liquid in the lungs is not what we want to do. So it has been shown that if you have mucus in the bronchial tree, the best way to break it up is to give a mucolytic. Bronchodilators, xanthine bronchodilators such as theophylline, your beta agonists, your anticholinergics, steroids, analgesics you have to use caution with, because you don't want to drop that respiratory rate too far. Neuromuscular blockade is oftentimes used when your patient is on the ventilator, and then sedation to decrease the work of breathing. And you need to know those drug classes and be able to identify what they need as far as side effects, risk factors, usual treatment, that sort of thing. Another thing the physician, as I said, might use is a ventilator if the pH is less than 7.25. Assist control is the oldest mode of ventilating. It controls the rate and the depth of respirations. It can only be used if your patient is paralyzed or apneic. And this is because if the patient is breathing on their own, they will get that same depth of respirations, that same tidal volume with every breath. For example, if you have somebody who's in respiratory failure and they're breathing 44 times a minute, and you have them set with a tidal volume of 1,000, they'll be breathing in 1,000 milliliters for every breath, 44 times a minute. That's not what you want. That's going to definitely cause trauma to the lungs. So you want to make sure that this patient is apneic or paralyzed when you're going to do this, so that it doesn't have to assist. If that's what you want, if you want to just assist their ventilations, you want to go with an SIMV, which is a synchronized intermittent mandatory ventilation. With this, they receive a set number of breaths from the machine, 8, and then the patient does everything else, okay? And they breathe the volume that they want to breathe otherwise. So this is, an SIMV is used for weaning purposes when you're taking them off a ventilator, because you can gradually decrease the rate the ventilator is doing, allowing the patient to breathe more on their own. CPAP, as I mentioned, is continuous positive airway pressure. It keeps those alveoli open. You can do this without being on a ventilator. BiPAP machine is what does that. It can increase the work of breathing because it will make it harder to breathe out and keep things the way they're supposed to do. CPAP is measured in sonometers. So is PEEP, which we've already talked about. And both CPAP and PEEP, by keeping those alveoli open, alveoli are only one cell thick, capillaries are one cell thick. So if you keep your alveoli open, you're putting pressure on those capillaries, making them not as open. And so thereby you will decrease the amount of fluid that returns to the left heart, and you will decrease preload, and you will lower their blood pressure. It may lower it significantly enough so that you may have to start a dopamine or dobutamine drip, but on the average it only drops at about 10 to 20 points. Your ventilator settings, your tidal volume. Now our normal tidal volume, as you're sitting there, you're breathing in 10 to 15 milliliters per kilogram. But for some patients that may be too high. So the physician will allow what's called permissive hypercapnia. Permissive hypercapnia allows the tidal volume to be between 5 to 8 milliliters per kilogram, allowing the PaCO2 to increase. And they will allow that to increase to a maximum of 100 millimeters of mercury. And they want to keep the pH at 7.2 or greater. Now, if somebody is intubated, they will have an endotracheal tube usually inserted, either nasally or orally, to maintain that. This is a hard rubber. It's a little flexible, but the usual size for a female is 7 to 8. The usual size for a man is 7.5 to 8.5. So the most common size you're going to see used is a 7.5. It will have a cuff on it that is inflated so that the trachea is not traumatized while it is in. While it is there, you will only use it for about 2 weeks, maybe 3. If your patient needs to be on a ventilator longer than 2 to 3 weeks, they will recommend tracheing the patient because that's better on the trachea. The alarms on the ventilator, you get your high pressure alarm. When the high pressure goes off, it means that there's something kinking or blocking that tube because it's taking the machine more pressure to push the air in. Usually the patient's coughing or needs suctioning, or the tubing is kinked, or they've bitten the endotracheal tube, or there's water in the tubing. Low pressure alarm, on the other hand, means that there's no resistance at all when you breathe it, when the machine pushes the air in, and there should be a little bit. And so the patient's either apneic, paralyzed, or there's a break in the system. They've coughed off the endotracheal tube from the ventilator, or they've coughed it out, or they've pulled it out. Whatever. You need to check these ventilators to make sure that there's not a problem with that when the alarm goes off. The first thing you look at is the patient, then the machine. They always keep an ambu at the bedside just in case, to help you in case there's an electrical outlet or electrical failure of some sort. Sometimes in order to keep that pH greater than 7.2, you may need to start a sodium bicarbonate drip. Remember, if you hang bicarb, nothing else can go with it. Nothing else can go with it. Pressure-controlled ventilation is used to decrease the volume trauma that can occur. The tidal volume will vary from breath to breath. Problems will occur as the lungs stiffen and a decreased ability to ventilate occurs. You'll have severe hypercapnia that can result from this, so high PaCO2 levels. Now you cannot do this if you have somebody who has an increase in intracranial pressure, pulmonary hypertension, seizures, or cardiac failure, because higher CO2s worsen intracranial pressure, worsen pulmonary hypertension, seizures, and cardiac failure. But if you have a pressure-controlled ventilation, the pressure is applied on inspiration. And you can have pressure support that can be applied with spontaneous respirations for when somebody breathes. Inverse ratio ventilation increases inspiration time and decreases expiration time. It maintains a mean airway pressure so that the alveoli stay open. It decreases the work of breathing. There's a disadvantage in that it does cause auto-PEEP, positive end expiratory pressure, and that can lower their blood pressure because it decreases preload and venous return. And you need heavy sedation to keep the patient from fighting the ventilator because this isn't normal. Normally you have a longer expiration than you do inspiration. PEEP, as I've mentioned, is your positive end expiratory pressure. Major side effect is decrease in cardiac output due to that decrease in preload and venous return. Also due to an increase in intrathoracic pressure. It will cause an increase in alveolar rupture. It is measured in sonometers. If it's too high, it will decrease your pulmonary capillary blood flow. It will decrease your surfactant production, so the alveoli don't open as easily, and it will increase shunting. If it's too low, more alveoli will collapse. If you have somebody who's on a ventilator, you want to elevate the head of the bed a little bit because it feels better to the patient. Secure that endotracheal tube with a collar. Make sure you can get at least one finger breath under that collar. You need to assess them, respiratory assessment, at least every 4 hours minimally. You hyperventilate them before suctioning. And again, do not instill anything down the endotracheal tube. In fact, they're not even recommending using the endotracheal tube to give meds during resuscitation events unless there is absolutely no other way in which to give it. You need to pre-medicate your patient possibly. Give them a little lidocaine or you want to a little sedation, a Valium, whatever, to help. When that patient is alone, you need to restrain them because do you know what your patient is what you do when you fall asleep? Do you know what your hands are doing? Most people don't. And so if they go up to scratch their nose, out comes the ET tube and the NG tube and anything else that might be there. So you want to restrain them when they're alone. When you're with them, you can unrestrain them. When their family's there, as long as they won't allow them to pull anything out. NG tube feedings are better than TPN in that it maintains the normal function of the gut and are necessary to start fairly early because you don't want them to develop a stress ulcer or curling ulcer. If they have an NG tube, you know what they need to do. Keep the head of the bed elevated 30 to 45 degrees. Change the bag every 24 hours. Check for residual at least every 4 hours. Reinstill that. Remember, if you have more than 2 hours worth of fluid or more than 100 milliliters of fluid, you want to hold that tube feeding and call the physician. And anytime you hold the tube feeding, make sure you flush the line. They also want to make sure that your tube feedings are low carb because carbohydrates break down to CO2 and water, and most of these patients retain CO2, so you don't want to elevate their CO2 levels any further. Diversional activities are important too. You might consider taking the television in or the radio on, and remember you want to put on what the patient wants to listen to, not what you want to. Now here are the medications again that we mentioned a little bit earlier. Your mucolytics that dissolve mucus, your bronchodilators that dilate the bronchial trees, such as your beta agonists and your xanthine diuretics, your anticholinergics, also bronchodilate, but they work differently by blocking other symptoms. Your steroids to decrease the inflammatory process, analgesics, and sedation to decrease the workload of breathing, and neuromuscular blockade that might be given. To maintain adequate tissue perfusion, you're going to keep that pulmonary capillary wedge pressure or occlusive pressure between 5 and 8. Your CVP between 5 and 10. And to do that, you may need to administer diuretics or decrease their fluids. You want to keep their cardiac output between 4 and 6. To do this, you may need to administer some vasoactive medications or inotropic agents to increase contractility. You want to block the inflammatory mediators, and this is why you may or may not administer steroids. There's different theories on it, but steroids are still being used fairly frequently. Monoclonal antibodies, antioxidants, and platelet activating factor inhibitors also block the inflammatory response. Your nursing care. You want to position your patient. Now, keep in mind when you're doing something, why you're doing it. So if you have a VQ mismatch, ventilation perfusion mismatch, pulmonary embolism, you want to put the least affected side down so that the most affected side will be oxygenated better. If it's bilateral, you're going to put the right side down because it's larger and more vascular. If you have someone who has alveolar hypoventilation, you're going to have them sit up because gravity will help them breathe better. If you have somebody who's had a pneumonectomy where they have actually removed one whole lung, you're going to have them lie on the operative side or on their back or sit up. Because if you have them lay on the non-operative side, any fluid or drainage or debris from the surgery will drain into their only good lung that's left, and they won't get a good enough oxygenation. So you need to think why you're doing this, why you're positioning the way they are. Are you doing it to improve oxygenation to that area, or are you doing it to cause fluid to drain in one area because you may want to put them in a special position to have all the fluid of the effusion drain into one spot so it can be removed? You need to think about what you're doing and why you're doing it. A pulse ox. Easiest thing in the world to stick on and pay attention to. Remember, you need to know what your normal hemoglobin is. Rest to decrease anxiety. Humidify the air. Because particularly if you have an endotracheal tube or a tracheostomy, you're bypassing the nose and the mouth. Coughing and deep breathing your patient. Suctioning your patient. Chest physiotherapy. Now, chest physiotherapy cannot be done with critical patients because they don't tolerate it. But it can be done with chronic lung patients, and they do better. And anytime you do chest physiotherapy, remember, if you do the whole thing, it takes about an hour. And so you don't want to time it just before breakfast or just after breakfast. You want to time it when it's the best time of the time to do it. So you want to do it first thing in the morning because they'll have all that junk from during the night. And you want to do it at bedtime so that they're clear when they go to bed. And then you want to do it maybe a couple hours after meals so that they, after breakfast and after lunch, so that they don't feel like throwing up all over you. But think about that. You need to, and anytime you suction your patient, make sure you give them a little bit more oxygen because you're sucking it all out. Elevate the head of the bed 30 degrees and maybe give them some incentive spirometry. Now make sure that they know how to use the incentive spirometry. When I had surgery a few years ago, they brought in an incentive for me to utilize. And the respiratory, because I went to the hospital I knew everybody at, so I knew what I was getting into. Respiratory came in and sat it down and said, "You know how to use this, don't you?" And I said, "Yes." And they walked out. And I left it there because I knew if I used it, it would hurt. So I didn't use it. Not necessarily the thing you want to do. So when my sister came in, she said, "What is this?" And I said, "It's an incentive spirometer." "Well, what are you supposed to do with it?" And so I told her what I was supposed to do with it, and she says, "Show me." Sadistic girl. She made me show her every 2 hours, just like I was supposed to. But I did not get any pneumonia, which was even better. This finishes the respiratory content lecture portion, and let me know if you have questions.